Hey everybody, good morning. I'm Kyle Fulton. I am an assistant professor of pediatrics at LSU in New Orleans, working at Children's Hospital in the craniofacial team. And there we go. I have no disclosures. So before I start and do my head shape lecture, I kind of want to explain to you what I do. So I tell people I'm a craniofacial pediatrician, and I get a grin and a nod, and then they just kind of, most of the time they don't really know what I do. So what I do is complex care pediatrics and specialize in the non-surgical, the medical management of kids born with craniofacial anomalies. Things like cleft lip, cleft palate, wonky shaped heads, craniosynostosis, Treacher-Collins, craniofacial microsomia, any birth anomaly from the neck up, basically. Assuring that all of my big team works well together, all to focus on the little one that you see there in the middle. Also providing the family and you all a one-stop shop. If you've got questions about the kids, call me. Anything they need done at the hospital, that's my job to help get that done and make sure that all of their care is moving forward. So the objectives today are to perform and document a systematic head shape exam, identify classic head shapes for plagiocephaly and single suture craniosynostosis, and to recommend appropriate and timely treatment of common head shape anomalies. To review normal skull anatomy and growth, because I know I was a board certified pediatrician before I did my fellowship, and there wasn't a whole lot I knew about head shapes. It's something I feel like we see a lot in Gen Peds clinic, but there's not a whole lot of formal education on it. So a quick review of our anatomy. So when we're born, the top of the skull is made out of 5 major bones separated by 6 major sutures. The sutures allow for deformation of the skull for birth, as well as rapid growth. And the reason the skull grows is due to increased volume inside the skull, due to the brain and increasing volume of CSF. Knowing that the brain also triple in size by 1 year old and is about 85% of adult size at 3 years old. So a common question I get is normal fontanelle closure. So the anterior fontanelle can close anytime between 9 and 15 months is typical, but it can range all the way from 3 to 26 months. The posterior fontanelle, a lot of times will close by about 2 months old, but even in newborns, it can be really difficult to palpate. And just because the fontanelle's closed doesn't necessarily mean you don't have any more growth there. It just means you can't feel it. As long as the little guy's got a normal head shape, has normal head growth and normal development, I'm not really concerned about craniosynostosis. I'm not super worried about a closed fontanelle. However, there are some things that can cause the fontanelle to either close early or close late. So for early closure, thinking of things like hyperthyroidism, hyperparathyroidism, hypophosphatasia, and rickets. Those are pretty rare. More commonly is the delayed closure of the fontanelles, and that would be things like hypothyroidism, malnutrition, trisomy 21, and hydrocephalus. Normal closure of the sutures. So for the metopid, it happens between 3 and 9 months old. When it closes, a lot of times it'll form a ridge here in the middle of the skull. And as long as the skull shape's pretty normal, it can be a really benign finding. So it's something that we see pretty regularly. And as you can see in these 2 leading Hollywood men, they still have metopic, kind of a metopic ridge. A lot of people do. If you feel your skull, you can feel it. It's just a lot more prominent in little guys because they don't have as thick a skin, as well as their skull's not as thick. So it's just more prominent and more visible. The other sutures actually don't close until your 20s, even though on a CT scan it's going to look closed and your head's not going to kind of fall apart if your skull was to kind of dry out. But yeah, they actually don't stop growing and actually close into your 20s. So when they close early, that's called craniosynostosis. So that's early fusion of the cranial sutures. If this were to happen, this typically happens in utero. So they're born with a wonky head shape. The incidence is about 1 in 2,500 births. In New Orleans, we see about 30 kids a year with single suture craniosynostosis, of which 97% of synostosis is a single suture, which is what we're going to talk about today. About 85% of these kids do not have an associated syndrome. However, about 6 to 10% are familial, some of which we know the genetics behind, some of which we don't. So why do we care? So craniosynostosis does increase the risk of increased intracranial pressure. In single suture kids, up to 42% will go on, if unrepaired, will go on to have increased intracranial pressure. In kids with multi-suture, it goes up to about 70%. These little guys, even with repair, are at increased risk of language delay, learning disability, including things like ADHD is included in those studies, or other developmental delays. However, there's not really good studies looking at how many of these kids will go on to develop increased intracranial pressure, because there's not really an ethical way to do that trial, to do a randomized controlled trial to do surgery or not. So a lot of these statistics are coming from other countries or kids that are detected to have synostosis later on in life, which may be a different pathology and maybe a different etiology than the most common, which is when they're born with it. So how our skull grows is it grows at those suture lines. And so craniosynostosis prevents perpendicular growth at that suture line. But then the skull grows at the other sutures to compensate for it. So with sagittal craniosynostosis, you see the sagittal suture is fused, so you can't grow that way. So you end up growing out the front and back. For unicoronal, can't grow that way, so you end up growing there. For metopic, you can't grow here, so you end up growing backwards. And then for lambdoid suture, which is the most rare, you can't grow at your lambdoid suture, and so you end up having kind of 3 different points of growth. So in general, how do you approach a misshapen head? So what I always teach my medical students and residents is you can typically answer most any question in medicine with a history and a physical. As you all mentioned yesterday with our resident lectures, with all the odd infectious disease things. So I get a really good birth history. I get a good gestational age, G's and P's, route of delivery, some of those prenatal concerns, as well as maternal health conditions. And the reason it matters is little guys, premature babies, are at increased risk of deformational plagiocephaly or brachycephaly. Those risks also increase with vitamin D deficiency. However, vitamin D deficiency puts you at increased risk of having late onset craniosynostosis. So CS, craniosynostosis, has an increased incidence in unplanned C-section. So as you can imagine, especially if it's a first-time mom or even a second or third, fourth, fifth-time mom who all of a sudden needs to have a C-section because the baby's head's a little differently shaped, and you can imagine that little guy's head shape coming out, it's not 10 centimeters, so he's a little bit harder to be born vaginally. Other risk factors for craniosynostosis are intrauterine head constraint, having twin pregnancy, maternal smoking, and maternal thyroid disease. So I'm always building my kind of risk when I'm going through my history. And when I've got a 4-time mom who had an unplanned C-section and has thyroid disease, it goes much higher on my list. However, breech molding can really mimic sagittal craniosynostosis. So we'll look at a lot of pictures in a minute. And then I ask us some specific head shape questions too. So what did their head shape look like when they were born? When did you first notice they had a wonky shaped head? And what's happened over time? So as I mentioned, synostosis presents at birth. So this kid's gonna have a differently shaped head since they were born. Typically you can see molding in these little guys, but it improves over time. So typical molding, come out with a cone shape, and it goes away over time. Craniosynostosis does not improve. You can have plagiocephaly or deformation at birth, but typically it improves over time as well. Always ask sleep position, and parents are always amazed when I can tell them where the baby sleeps in comparison to mom. So the baby always looks to mom when they're asleep, or the last place mom was, so the door. So baby sleeps here, baby looks to the left and looks at mom. So always ask that, and kind of what their sleep position is. Are they on their back? Do they prefer to look to the side? Are they starting to roll over yet? And head tilt or torticollis. So this is a huge risk factor for having plagiocephaly. And always asking the family what's changed over time. Has it gotten better or worse? Because a head tilt and torticollis can make any head shape worse and really muddy the waters. And I'll show you a great picture of a little guy that Dr. Vigor sent me with a gnarly head tilt that really confused us all. And then I get a good developmental history. So kids with delayed motor skills have an increased risk for plagiocephaly. So again, doing a good exam as well is how I diagnose most of my kids. So I gave you all this form. It was made by a mentor of mine. And when I run plagiocephaly clinic, when I'm there, I print one of these out for every single kid because it's impossible to remember whether it was right or left or which way the nose went when I walk out of a room. And sometimes I'll get sidetracked and forget to do a full exam. So I always take this form in with me and document it there each time. So the first thing I always look at is my percentiles. So it's something we all look at every time before you go into a well visit. Look at their percentiles. Is their head circumference proportional to the rest of them? And if it's wildly different than last time, who measured it? And is this kid going wild? Because I measure a whole lot of head circumferences in my clinic, not because I don't trust my MAs, but because it's really difficult to get a good head circumference. Microcephaly in general is not really associated with most of the craniosynostoses. Macrocephaly seems to be more common because geometry, a circle, is the smallest area that you can fit with the biggest volume. So when you start making a different shape and you have the same volume, you end up with a bigger perimeter. So we're gonna walk through the exam when we talk about single sutures, when we kind of talk about the different head shapes. And most of it's pretty self-explanatory, but the one thing you'll notice that's not on there is frontal bossing. Hate the word. Every single person in here can use that term, and it means something different. So I try not to use it. I try to get my residents not to use it. I tell them, explain what you're seeing. Because frontal bossing, it's not a huge descriptor. So yeah, I don't use it, and it's not on the form. The one thing that is a little different on that thing that we are not used to kind of looking at a head shape is from the side. So looking at AP diameter, so front to back, you can see, I'd say those two are kind of short, that one's kind of long. And when talking about height, so turricephalic means tall, so versus a tall forehead or a tall occiput. So this little guy's got a tall occiput. This one's got a tall occiput and a tall forehead. So I would call this little guy turricephalic. But again, I try not to use those words in my note because it's not a common word. And then the other thing I'm looking at from the side, do they have a prominent forehead and occiput, or just a prominent forehead like this little guy? So he's got a prominent forehead and occiput. And now kind of walking through and looking at the different shapes. So the most common craniosynostosis is sagittal. So looking at your head circumference, it's going to be relatively macrocephalic. Their anterior fontanelle is going to be triangular, typically, instead of that nice diamond shape that you see there. And it's blunted towards the sagittal suture. And then palpating the sutures, you'll feel a ridge over that sagittal suture. In this little guy, who's a newborn, I also put a tiny bit of little pressure on the sagittal suture to see, is it actually overriding or is it a ridge? Because if it's a ridge and it's synostosis, that suture's not gonna flex. But in a newborn with overriding sutures, you can flex that suture just a little bitty bit. Sometimes you'll even feel it when you're just putting their hat back on. And it's not something I tell my students and residents to do, but you all who have been practicing many years know how much pressure to put on a baby's head. Not much. I'm not worried about you poking a head too much. So it doesn't take much pressure at all. Top-down view, they're gonna be pretty narrow and elongated. And you'll see I've got some stuff underlined and bolded, and those are kind of the hallmarks, or the things that I look at to differentiate between sagittal synostosis and something else. So these little guys, when looking from above, the widest point of their head is not biparietal. So it's not back here, behind the ears. It's at the ears or in front of the ears. And sometimes they just don't have a widest point. And then looking at their side view, they typically have a prominent forehead and occiput. And then facial view, they're typically pretty symmetric, but they have that large prominent forehead that you can see from the front. So like I said, it's the most common. It's about 40 to 50% of all cases of craniosynostosis. It's more common in males. And the age for treatment ranges from about a month and a half to 4 months old to do an endoscopic repair, which is less invasive, less chance of needing a blood transfusion, and it's just less recovery. However, you have to wear a helmet for about a year after any endoscopic craniosynostosis repair. Open repair we do after 4 months old. It is a gargantuan surgery. They bring my plastic surgeon and neurosurgeon work together. They expose the skull from here to here, and they make a bunch of cuts, and they do a lot of crazy stuff. However, afterwards you don't need a helmet, but 99% of these little guys end up needing a blood transfusion with any open craniosynostosis repair. So we always try to get the kids in before 4 months old to at least give the family the option of endoscopic repair or open repair.
How do they do an endoscopic?
So an endoscopic repair, they basically go in, and I'm way oversimplifying this, as I do with all of this stuff, because I'm far from a surgeon. So they go in, they make a cut in the scalp here and here, and then the neurosurgeon and plastic surgeon go in and they basically make a cut in the skull and do a suturectomy. Basically, it's about an inch and a half to 2 inches. About an inch and a half. And they just take it out. And then, over the next year, they end up wearing a helmet that helps gravity reshape the head. They actually take the suture out. Yep, they take the bone out. Versus the open repair, it's called a barrel stave technique, and I didn't put any of the pictures in there because 30 minutes is a short presentation for this. But they make a bunch of cuts and they barrel stave so they can make the head shorter and more round. Now, let's see some other pictures, if it's gonna work. There we go. So some more pictures. The little guy with red hair, he was a little bit older when we saw him. He was about 8 to 9 months old when we saw him, so we didn't have a chance to do an endoscopic repair. But these are his CT scans. You can see his fontanelle was pretty big, but it was triangular and blunted towards the sagittal suture. You can see these little guys were a little bit younger, but they had that prominent occiput and forehead. You can see their narrow head shape with the widest point at or in front of the ears, and more. So you can see all of these little guys have just a gnarly big forehead. Always, like, mentally I'm thinking it almost looks like a dolphin. Like they've just got a huge forehead. And then from top down, these are all the eyes are up front. You can see the widest point of this little guy's head is bitemporal. His head looks like a bullet. This little guy really doesn't have a widest point. And then this little guy is super long, and its widest point is right there, so in front of the ears. And that is how I differentiate sagittal craniosynostosis from breech molding. So yes, breech positioning does increase your risk of having craniosynostosis, but with kids with breech, their widest point is behind their ears still. So if you've got a little one that's widest point is at or in front of the ears, send them to me. All right. So there's all of those little guys, and this PowerPoint will be made available to you after. Next up, the next most common is metopic craniosynostosis. So again, these little guys have typically not as macrocephalic as as sagittal, but typically not microcephalic. So you're going to be able to feel that metopic suture is going to be closed, and they're going to have that ridge, and then as well their fontanelle typically is a triangle blunted towards the metopic suture. A top-down view, they're going to end up with that classic teardrop shape or trigonocephaly, so three-pointed hat. And the differentiation between benign metopic ridge and metopic craniosynostosis is this. As well as when you look down, you can frequently see the lateral globes, and that's what our eyebrows do, is they protect our eyes. So in these little guys, they don't have that brow protection, so if someone were to punch them from above, or a baseball or something coming, they don't have that eye protection. And that's why we kind of do the repair on this little one, in addition to the other issues. So facial view here, a lot of times they're symmetric, but they have these, what I call evil eyebrows, because both of them are arched. So both eyebrows get arched even when they're asleep. You can see this little guy here. And a lot of times their face looks like it's small and put on a bigger head. This kid, not as much, you'll see in a second. There was a cartoon villain a couple years ago that was blue, and his name was Megamind. And when you think of him, he's got a big brain and a tiny face and those arched eyebrows. And that's kind of what I think these little guys look like. There we go, perfect. So you can see, arched eyebrows, big head, a little face. So here we go. So this little baby's asleep and looks surprised. This one is awake and looks very surprised. But you can see that teardrop shape here, here, here. And that fontanelle, while it's a diamond shape, you can tell it's just not super normal. Incidence for it is about 1 in 10,000. It's, again, more common in males. These are more likely to be associated with a syndrome. Up about to 30% of the kids that have this have a syndrome. The most recent little guy I had with this has trisomy 13 and is a month and a half old and doing wonderful. So age for treatment, again, for endoscopic is going to be down 1.5 to 4 months old. But open repair on these guys, we wait a little longer because they're remaking this part of the skull. They actually take the eyebrows the bony part of the eyebrows and the top of the nose off and remold it and put it back on. And so the tension there, they need a little bit thicker skull to be able to withstand that reshaping, as well as the tension afterwards tends to be pretty significant in this area. So we wait a little longer till their bone's a little thicker before we do that repair open. All right, so. And like I said, versus isolated metopic ridge, they're gonna have a normal head shape. When you look down from above, you may see that ridge, but in general, their head does not look like a teardrop. They also don't have bitemporal constriction, meaning it looks like you pinched them right here in the temples, and they kind of have a narrow face. And they have the normal forehead contouring. So if they didn't come out looking like this, with a teardrop shape, and you see that metopic ridge develop starting at 2 to 3, 4 months old, likely a benign condition that's going to get less prominent over time. The next single suture would be unicoronal craniosynostosis, so the one right here. Again, their head shape's going to be more normal because they have a pretty round head shape. It's just kind of a differently shaped oval or roundness. They're going to have that fontanelle is going to be open and triangular, but blunted to the side that's closed. So you can see right there, this suture's closed, and there's the triangle. They may have a palpable ridge over the coronal suture. However, the way that the coronal sutures grow is overlapping. So a lot of people you can feel a ridge. Even as you get older, you can feel kind of a step off from the front to the back. And my friends that do craniofacial pediatrics as well, there's no specific name for this, so we call it the headband sign. But you can see, especially when they don't have much hair, that it looks almost like they've got a headband on, and that can be normal if they have a normal head shape. So like you can feel it on my head, and a lot of people, you can probably feel it on your head. It's just how those sutures grow. A top-down view, they're going to have their forehead is going to be retruded on the side that is affected, and you're going to be able to see the lateral globe from above. So when looking from above, you can see a little bit of that eye, and there's going to be more cheek visible on that side. Their widest points not going to be symmetric. So you can see on the left side, it looks to be around the ear, but over here it's temporal, so it's askew. However, kind of the hallmark features of unicoronal synostosis is the facial appearance. So that the side that's affected, they end up with a swept up eyebrow. They have a curious eye of that one side, and they have facial scoliosis, which you may not have noticed until I mentioned it. So when you draw a line down this little one's face, it's not straight. She's got some scoliosis, and her nose, there's a nasal twist off away from the side that's affected. So it's not uncommon for these little guys sometimes to go to ophthalmology first, and ophthalmology to see them because they have different sized eyes. So I think since I've been back in New Orleans, we've had about 2 or 3 that got MRIs, and the radiologist is the one that called it because the eyes are actually the same size. It's the sockets, and it's the bone structure that's a little different. So you can see here again that curious lifted eyebrow on that one side, and it's actually called a harlequin eye deformity, but you can see it on CT scan. This left side, they have a nice bony, you can feel the ledge there for their orbit. On that side, it just kind of slips. And what it is so this suture doesn't grow, and so the forehead is kind of swept back over time and just kind of pulls that forehead back as the skull grows. It's about 20 to 25% of craniosynostosis. It's about the same incidence as metopic, depending on what literature you look at. It is the one that's more common in females. About 30% of these kids have an FGFR mutation or a twist 1, these can lead to C-spine changes. So in little guys that have unicoronal, I tell them no gymnastics, no diving, but then we see them yearly after surgery, and so I get a CT or a neck x-ray when they're about 4 to 5 years old to make sure that their C-spine doesn't have any issues. Or if we're going to do a head scan, I'll just have them add the C-spine to it once they're a little older. Again, treatment, 1.5 to 4 months old. This one's not as common as the metopic and sagittal to do endoscopic. Newer docs, younger docs are doing it, and we're seeing good results. Historically, the surgeons didn't like to do it because you could still end up with some asymmetry from side to side. And this is same as metopic. We wait till around 9 to 14 months old to repair this whenever we do an open repair. So here's some more pictures. You can see that side is the affected side. It's pretty noticeable. This little guy just looks like he's in an ad for something giving you a wink. But you can see that facial scoliosis again, and that nose kind of going off to the side. And you can definitely see the forehead protrusion on that photo. And lastly, of the single sutures is lambdoid. So this is the one that everyone gets worried about because it's confused with plagiocephaly. So these guys are going to have a normal to relatively macrocephalic head circumference. Typically have a ridge over the lambdoid suture. A top-down view is going to be a rhomboid. So the forehead on the affected side is retruded. Sometimes it almost looks like the opposite side is actually just growing more. The occipital shape, you get flatness on that side. And again, your widest point is going to be askew. Your ear position, we know with plagiocephaly that pushes the ear forward. In lambdoid, it actually holds the ear back. So you're thinking that the skull's not growing, so it kind of holds onto that ear and doesn't let it grow. Side view is going to be pretty typical most of the time versus plagio we'll see in a second. Posterior view, this is the most important for lambdoid. You got to correct for a head tilt. So when we do plagiocephaly clinic, there's typically 3 of us in a room, and one of us holds the head steady, kind of level with the ground, while the other 2 do the exam, and then we swap. So they have a skull base tilt. It's lower on that affected side. Like I said, it kind of holds it down. But you can see, you draw a line between the mastoid processes here, and their ears are different levels. When you have vertical dystopia of the ears, that's not normal. Horizontal dystopia, like one ear being forward or back, can be okay, but up and down is not normal. You get a mastoid bulge on the affected side, so you'll feel the ridge over that lambdoid suture as well as a bulge over the mastoid fontanelle, because that's where the brain and the skull are trying to grow. You end up with different vertical ear positioning. And then on facial view, they end up with an opposite parietal prominence. So this is the affected side in this little girl, but she doesn't bump on this side. This is all due to skull growth, and I'll show you a diagram in a second that gives you the mechanics of this. Again, their face as well is not symmetric. So you can see that she's got a little facial scoliosis too. So looking, the hallmarks for lambdoid are that skull base tilt, like I talked about. You can see it in all these little guys. You can see the ipsilateral, so the same side mastoid bulge. And then the vertical ear dystopia that you can see on all those pictures. And this is kind of a diagram why. Right here, this lambdoid suture is fused, so there's a mastoid fontanelle right there that you grow at, and then you grow in this opposite corner as well. And then there's your contralateral parietal bulge. So this is the most rare of the single sutures. It's only about 2% of all kids with craniosynostosis. We see about 1 a year, sometimes 2 because Louisiana's weird. It's again more common in males. However, some studies it's super rare, so even huge centers like in Seattle where they see 100 kids a year, they're only just seeing 1 or 2, 3 kids a year. So it's really tough to do big studies with lambdoid synostosis because it is very rare. Again, endoscopic repair, 1.5 to 4 months old, but it's another one that's not as commonly done endoscopically because concerned that when you have some asymmetry of the skull, if you're doing the helmet, it may not correct it as much as a traditional repair. However, this is becoming more common, doing endoscopic repair, because as time goes on, you get progressive facial scoliosis and you get progressive forehead differences. So there's thoughts that if you correct it early on, you may prevent some of this worsening of facial scoliosis over time. So the big thing is lambdoid versus positional plagiocephaly. So we are always taught a parallelogram equals plagiocephaly, okay? And a rhomboid means lambdoid synostosis. You can see these little guys. This is positional plagiocephaly. Push that side forward. This little guy, this is the short side, as well as it's a little tougher to see, but this is the retreated side on this kid. So looking at plagiocephaly, again, their measurements are typically going to be normal to sometimes macrocephalic. For these kids, the top-down view is my preferred exam. That forehead's going to be pushed forward on that flat side. Again, I can always tell this baby slept looking to her left, so her mama slept right here compared to her. The crib was on mom's right side, and the baby looked to mom on the left. You have the flattening on that one side that pushes the forehead. They have that parallelogram shape. And the ears, again, I put my fingers in their ears to kind of tell where they're at, and typically the affected side should be pushed forward. Side view, a lot of times it's going to either be normal or they can have a tall occiput. So it just they don't really have an occipital prominence. It just goes straight up. Posterior view, when you correct for a head tilt, their ears are normal. They do not have vertical dystopia of their ears. They don't have that mastoid bulge either. Facial view, most of the time these kids are symmetric. Every once in a while we'll get a kid with facial asymmetry, one cheek being bigger than the other. And so that can be really, can throw people off. That's a reason to come see us. So in general, depending on what study you look at, between 22 to 50% of kids will have some sort of plagiocephaly at some point in their life. Plagiocephaly skyrocketed starting in the early 1990s when we started doing back to sleep. And a skull shape difference is not enough of a reason to not put them back to sleep. So even in the babies that have gnarly plagiocephaly, I still talk to the family about putting them on their back when they're sleeping. This as well is more common in boys. It's typically acquired in that first month to 3 months of life when they're not doing a lot of turning, when they're not rolling over yet. They don't have that great head control. And like I said, the flat responds to the side the baby sleeps on. About 20% of these kids will have some degree of torticollis as well. So here's that, like they just don't have an occipital prominence at all. It just goes straight up. So there is an increased risk of kids with hypotonia and developmental delay developing plagiocephaly. So these are kids that you want in early steps. You want to try to talk to the family about repositioning, trying to keep them off their back as much as possible. And there is a correlation between plagiocephaly and poorer cognitive outcomes in elementary school. Plagiocephaly is not what's causing the cognitive differences. I think it's the underlying developmental delays and things that led to the plagiocephaly. So brachycephaly is kind of a branch of plagiocephaly. Brachy, short, cephaly, skull. So they end up with this kind of short, squat skull. You can see just symmetric flattening over the back of the head. This is typically symmetric, or typically positional. And while we used to lovingly call our NICU babies toaster heads because they had that narrow wide, because our nurses were great about turning them on their sides, over time, We've kind of stopped repositioning them on but only on their sides. Now the babies in the NICU sleep on their back as well. And so we see this in little guys from the NICU, especially those with that were intubated and sedated for a long time, or those little guys that have a trach, have really bad brachycephaly, and just flat back of the skull, which again, flat skull is much preferred compared to not being able to breathe. So needing a trach. So when I get NICU consults about brachycephaly in these kids, I tell the NICU docs there's not much I can do. We can reposition them, but if they need to be paralyzed and sedated to get their trach done and all that, then that's much more important. So in general, so my animation's off a little bit. So typical counseling for plagiocephaly: increased supervised tummy time, core strengthening, less time on their back, less time in their car seat, more time kind of sitting up in a like a infant carrier with mom, repositioning their crib or bed. So if you literally just turn the bassinet upside down, then the baby looks the opposite way to look at mom. And then mom can see their face instead of looking at their feet. If they have torticollis, get them in physical therapy early. This is a kid that from the nursery, I will call the physical therapy team and say, hey, I've got a newborn, has torticollis. Can you get them in quicker than the 3 to 4 to 5 week plus wait list? Because early intervention for these kids is key to not end up like this little guy who did physical therapy early on, but just still had gnarly torticollis. And so Dr. Vigor sent this little guy to us after doing physical therapy, but his facial asymmetry is what struck us. So we ended up doing a CT in this little guy, but he had normal head, his skull was normal. It was all torticollis that caused this facial asymmetry. He's even got some mandibular asymmetry. But for him, Dr. Elliott, who's a PM&R doc, is in our plagiocephaly clinic as well. He had done a lot of torticollis treatment with PT, so she Botoxed him. And this is him at 8 months oldish, 9 months old for his well visit, maybe a year old, because he's got teeth. So, but anyways, this is the same little guy. So you can see with PT and Botox, his facial asymmetry is pretty much resolved. He's got a little bit more of a chin on that side, but not enough that anyone would notice. So now, helmets and plagiocephaly, the bane of my existence. So it's a hard shell filled with a foam lining. It redirects skull growth. Basically, it's full where you have roundness, and then there's space on that flat spot, allowing the skull to kind of fill in that hole. It fits, like I said there. They only work in asymmetric plagiocephaly. So in kids with brachycephaly, there's quite a few papers out there that say brachycephaly improved with a helmet. It was not a randomized controlled trial. They just wore a helmet and it got better. So most of the time, I don't recommend a helmet with brachycephaly. Typically only when we've got pretty significant asymmetric plagiocephaly. We need to start a helmet by 6 months old. If you don't start a helmet until 8 months old, it's not gonna work, because you all have seen that head circumference growth curve a million times. It starts leveling off at 8 to 9 months old. So when you have a lot of skull growth is when you've got potential to make change. So if you've got a little guy, you're worried about their head shape, don't wait until their 6-month-old visit to see how it's gonna get better. Send them to me at that 4-month mark if you're concerned about them. Because once they get to us, you refer them at 6 months, they don't see us till 7 months, then it rains and there's a flood and they can't get to us. And then by the time they get to us, we can't do much. Same with little guys coming to us at 12, 14, 16, 18 months old. By that time, the only thing that I can offer them is a cranioplasty with our surgeons, and that's a big surgery for a wonky shaped skull, and I don't know that my surgeons would do that. So So with the helmet, you wear it for 23 hours a day for 4 to 6 months, depending on when you start it. Typically, it's till about a year old. The cost is up to $2,500. Most insurances only cover it if there's significant asymmetry. Some insurances don't cover it. TRICARE, forget about it. Yeah, so there's been one randomized controlled trial with helmets. This was done in 2014. There were 84 infants. They put them in 2 different arms. 40 got conservative treatment, 13 got helmet therapy. Only 10 out of 30 wore it for the entire treatment until 12 months old. Most of the parents stopped because they were either happy with their head shape, they had side effects, which we'll talk about. They weren't happy that it wasn't getting any better, so they stopped, or the kids get big enough to start taking them off by themselves. And you have to come back for weekly to every other week visits too during this time, especially early on, to get them refitted. So again, it's another time commitment for the family too. After the first month or two, they kind of go to 3, like a little further out visits, but it's a big time commitment too. 73% of these families had issues with it actually fitting, or they'd turn around and look at the baby and it would be sideways. So it would shift throughout the day. So the primary outcome is they had a head shape specialist look at the kid before and grade them, and then they had them look at them at 24 months old. The results were they couldn't tell the difference. Couldn't tell the difference who got a helmet and who didn't get a helmet. But they all reported at least one side effect. So some babies hate the helmet and they just scream the entire time it's on. A lot of them have skin irritation. We're in Louisiana, so they get swamp skull. It's just sweaty and hot. They end up with lots of seborrheic dermatitis. They end up unpleasant odor. They end up stinky. And another big one is the parents felt like it hindered their cuddling and their bonding with their kid because there's a helmet in the way. When you're cuddling, you can't cuddle with a helmet. So their conclusion was that helmets had no increased benefit, but substantially higher cost and time commitments from the family over conservative management. So what do we do in our clinic? We don't recommend helmets routinely. If I see a kid that's got significant asymmetry, especially starting to have facial asymmetry, that's when I'll talk about doing a helmet. If I've got a family that's pushing for a helmet and they want it, absolutely, I'll write your prescription, you can go get a helmet. But I always counsel them saying, it may or may not help. It's gonna get better on its own whether we do a helmet or not. But another one that I'll do, sometimes if I got kids with developmental delays, I'll do it. It may help a little more because they're not gonna get those milestones as quick when their head's growing as much. However, when you don't have good head control and you put, it's about 6 to 8 ounces helmet on it, it adds weight to the skull. So they end up, like, it's not gonna delay their head control, but it's another thing to think about too. So yeah, I'm not anti-helmet, but I'm not pro-helmet. And so what do you do for a misshapen head? 2 slides left. Don't get imaging, because most of the time you'll get an x-ray and it's gonna say, cannot rule out craniosynostoses. Because it's tough to see the sutures, especially when it's an adult radiologist in the field reading it. Yeah, so don't get imaging. When you're trying to decide, is it plagiocephaly or craniosynostoses? If you think it's plagiocephaly, talk about conservative management. If that doesn't help, get them in plagiocephaly clinic. In our plagiocephaly clinic, it's our PM&R doc, Dr. Elliott. It's our plastic surgery PA, who is at all of our head shape clinics for craniosynostosis and plagio. And then I'm there as a tiebreaker. Or if there's a kid with a really wonky head shape, I'll go in. Send them soon if you start noticing asymmetry or torticollis, because Dr. Elliott as well is there to talk about doing Botox if needed. She also does a lot of great stretching exercises. And again, ideally no later than 6 months old. If you think they've got craniosynostosis, send them to the craniofacial team and call us. Especially if you've got a kid at that 3 to 4 month old mark and you're like, I can't really tell, call me, because I want to get them in early enough so that we can give that family the option of endoscopic repair versus an open repair that we have to wait a couple more months for. Well, all right, let's see. So, what to do with a misshapen head in general? So this is kind of my changing practice. If you've got an unknown head shape or you're pretty sure it's plagiocephaly, don't get imaging, just refer them to plagio. If you're not 100% sure, you can take pictures, put them in your note. Here's a demonstration of the views that we do. We actually started a QI project when I was in fellowship at the beginning of COVID, having parents send us these, and we prevented so many kids from having to travel during COVID to come to the referral center for us to see them when we did these head shape pictures. If you're in the LCMC EPIC system, just send me an EPIC message and I can look at head shape pictures. If not, send me an email with a couple of the shots. If I don't get back to you, a lot of times those go to spam. So call the office and talk to me. I'll gladly kind of glance at a photo and tell you, yeah, you need to come in, or we can hold off for a little while. And now, then the last page basically just has my contact info on it again. And then if you're interested in reading more, all of these articles are wonderful kind of updates on all those things, including the AAP article from, I forget when it was, 2020, The Misshapen Head. So, thank you.